Hello, everyone. First of all, I would like to thank you for the opportunity to speak to you today. My name is Dr. Luis Goncalves. I am the Director of Fetal Imaging at Phoenix Children's Hospital in Arizona. And I am a former obstetrician and now pediatric radiologist. And I do basically my life dedicated to prenatal diagnosis. And I would like to share with you today applications of PureWave technology to prenatal diagnosis, particularly in cases of difficult anomalies. And also I'm going to share some very cool images that can be obtained, using the high resolution provided by these probes. So onwards to the presentation. I have two main objectives. The first is to provide examples that highlight the improvement in anatomical detail achieved by scanning at higher ultrasound frequencies using the EL8-4 and the V92 megahertz probes. And the second is to highlight the potential utility of microvascular flow imaging for the evaluation of prenatal vascular disorders. Let's briefly review the technological aspects of the presentation. First, I would like to focus on the EL18-4 transducer. This transducer is an ultra-broadband probe that generates frequencies from 2 to 22 megahertz, combining superb 2D detail resolution with penetration. We use it in a majority of our pediatric patients, and it has been proven extremely useful for obstetrical applications as well. The L18 probe uses PureWave crystal technology arranged in a multi-row array configuration, providing focus on both the elevation and azimuthal planes. And even though the label of the probe states EL18-4, as mentioned before, the broadband frequency is actually larger. It ranges from 2 to 22 megahertz. So you combine really deep penetration with exquisite resolution in the near field. The second probe we're going to talk about is the V92 probe. The V92 is also manufactured using PureWave crystal technology and combines a broadband ultrasound frequency from 2 to 9 megahertz, and also has added features of mechanical 3D and 4D capabilities, so you can do three-dimensional imaging, four-dimensional imaging, as well as imaging of the fetal heart using stick technology. This has turned out to be our go-to probe for obstetrical exams. So if you compare the V92 with the former V62, you're going to see that the V92 is a light probe. It's a very ergonomical probe that can be used throughout the exam without a need to resort to conventional convex probes, unless the penetration is not sufficient enough and you need to resort to something like the C51, which is not usually the case in our patients. Most of them we can image with the V92 probe. And when we want even higher resolutions, we resort to the EL18-4 probe. So I'm going to start, with a recent case that we had. It was a baby with apparently simple anomaly, imaged at 15 weeks and 5 days. And the case highlights not only the resolution of the probe at the early gestational ages, but also highlights the utility that this kind of resolution has in solving a very difficult problem. So this is an axial sweep from the upper abdomen to the pelvis, and I'll let the video clip run a few times. We'll go over the specific abnormalities in detail in the next few slides. But the main findings of this video clip are as follows. First, you notice that there is a massive dilation of the urinary bladder. There is a large amount of ascites. The abdominal wall is distended and flaccid. And the kidneys are hyperechogenic and dysplastic. With this constellation of anomalies, we began to think that the baby has megacystis with a lower urinary tract obstruction. The differential diagnosis for lower urinary tract obstruction includes posterior urethral valves, urethroatresia, prune belly syndrome, megacystis microcolon, intestinal hypoperistalsis syndrome, and cloacal anomalies spectrum. As you can see in this image of the abdominal circumference, the skin is very flaccid and enlarged. There's a large amount of ascites, and the liver is in the midline. In the first image set of this slide, you see a dilated urinary bladder, you see ascites, and you see a dilated posterior urethra indicated by the arrow at the bottom of the image. The next two images show two structures on each side that turn out to be the testicles located still in the abdomen. And we know these are testicles because of the mediastinum testis, this hyperechogenic line that goes into the testis. So these are not ovaries or testes, and therefore this is a male baby, and that facilitates our diagnosis. So at this point, my primary differential diagnosis are posterior urethral valves versus prune belly syndrome. The kidneys are hyperechogenic, and they have lost their corticomedullary differentiation. These are consistent with dysplastic kidneys with poor renal function. In this slide, I'm showing two axial sweeps through the lower extremities, the first using the EL-18-4, and the second using the V92 transducer. The first video clip shows bilateral club feet, which is expected in these cases. However, the second video clip shows that the legs are crossed in fixed position, suggestive of fixed contractures at the hips and knees, or arthrogryposis. Arthrogryposis is not a typical feature of either prune belly syndrome or posterior urethral valves. This is a render view of the left lower extremity using TrueView. So we were able to obtain this really quickly because we were scanning this baby already with the V92 probe at the time. In this slide, I'm showing you a sagittal sweep from left to right through the fetal body. This image caught my attention because of the unexpected position of the dilated posterior urethra. As you see here, the dilated posterior urethra is oriented posteriorly towards the back of the baby, and with not much tissue between the posterior urethra and the posterior wall of the baby. Normally here we will have a rectum in case of a boy, and a rectum and a uterus in case of a girl. And also normally these urethras are usually oriented anteriorly and not posteriorly. Note also that the spine appears to end at this point here, which led me to suspect that this baby could have some sort of caudal regression or sacral dysgenesis. We then decided to do imaging in the coronal plane, and here you have the lowermost ribs, and you have the lumbar spine, and we're going here towards the sacral spine. Notice that the sacrum is not well seen. These are the two iliac wings. They are kind of like a little closer to the midline than usual, and that's the posterior urethra. So if you count from T12, this will be L1, L2, L3, L4, L5, S1, and S2. It seems that everything below S2 was not present, which led me to the diagnosis of partial sacral agenesis and caudal regression syndrome. This is a 3D rendered image of the spine that basically confirms that there's nothing here interposed between the iliac wings, so the sacrum is completely absent. And this is a close-up of the spinal canal, where you see the spinal cord extending all the way down to the sacral defect. In normal circumstances, the spinal cord should end at L1, L2, and this is going to become very apparent and simple to understand once we go through the next slides, later in this presentation. Lastly, because of all these anomalies, I suspected that the baby could have anorectal malformation associated with that, and I decided to follow the bowel all the way down to the rectum. So this is the distal portion of the bowel, the colon. This is the sigmoid colon. This is the rectum. And the rectum terminates above the bladder, consistent with a high anorectal malformation. So all of these anomalies were diagnosed with confidence at 15 weeks and 5 days of gestation, thanks to the superior resolution of these high-res probes. So the summary of findings in this case is a male fetus with a lower urinary tract obstruction, but had also severe associated anomalies, including partial sacroagenesis, tethered cord, high anorectal malformation with imperforate anus. And the patient decided to terminate the pregnancy based on the findings of the exam. Now let's go through examples of normal anatomy with the EL-18-4 and V92 probes. So these are normal anatomy planes that you obtain during obstetrical exams, highlighting the high resolution achieved with these probes. So let's begin with the facial structures. These are sagittal and coronal views of the face with the EL-18-4 probe, showing the lips and nose with very good detail. This is a high resolution image of the fetal orbit at 32 weeks of gestation. This was obtained as part of our unique program for prenatal diagnosis of retinoblastoma in patients at risk. So we image the eyes in patients at risk beginning at around 32 weeks to see if we can identify retinoblastomas before birth so they can be delivered and treated earlier, trying to get them a better prognosis. So this probe is instrumental for our program since we can really see the anatomy of the eye as much as we can see in the neonate as shown here. So this is the baby's eyes cornea. This is the anterior chamber, the iris, the lens, the vitreous, and here is the retina. These are three-dimensional images of the fetal face obtained with the V92 probe, highlighting the anatomy of the palate, reconstructed using this probe, using here just multiplanar imaging. Here is now with the rendered view using three-dimensional rendered image using the skeletal mode. And here a zoomed view of that palate comparing to the diagram, showing here the palatine suture separating the maxilla from the palatine bone. In terms of cardiovascular imaging, here's a comparison of a fetal heart imaged at 20 weeks and 1 day using the C51 probe. And here the same heart imaged with the EL-18-4 probe. So the fourth chamber view, left outflow tract, pulmonary artery, and three vessel and trachea view. Much higher resolution using the EL-18-4 and still good penetration in the deeper fields. So this probe can be used for your anatomical exams. This is another image, in a little more detail, zoomed up of the four-chamber view, highlighting here the mitral valve, tricuspid valve, foramen ovale, and flap of the foramen ovale. And here are the pulmonary veins. Here with color going through the left and right ventricles. Another four-chamber view now at 29 weeks and 5 days using the V92 probe. The V92 probe with color Doppler through the four-chamber view. The ductus venosus, the inferior vena cava and hepatic veins. And here the left ventricular outflow tract in grayscale and with color Doppler. Now, microvascular flow imaging can be a major asset in evaluating the fetal heart due to the increased sensitivity to blood flow and still maintaining blood flow within the chambers and vessels. So let's go through some examples. Here's an image of the four-chamber view of the fetal heart at 20 weeks of gestation using the EL-18-4 probe and microvascular flow imaging. Notice here the exquisite evaluation of the pulmonary veins draining back to the left atrium. So you see the four pulmonary veins going back to the left atrium. Here's imaging of the aortic arch and the ductal arch using microvascular flow imaging. So this is the aortic arch and this is the ductal arch, all superimposed with each other, using only to the ultrasound and microvascular flow imaging. Here's a four-chamber view of the fetal heart And this is very useful for identification of small ventricular septal defects due to the high sensitivity and still maintaining color within the chambers. Here is the left ventricular outflow tract with microvascular flow imaging. The 3-vessel and trachea view, pulmonary artery, aortic arch, and superior vena cava. Here are pulmonary veins going back to the left atrium in another example using microvascular flow imaging. The V92 probe is also a probe that can be used for fetal heart imaging using 4D technology, as I mentioned before. So this is the original acquisition of this heart at 29 weeks and 5 days. So this is the image being shown without any manipulation. This is the same volume now rendered to demonstrate the 4-chamber view. So this is the ventricular septum, tricuspid and mitral valves, the inferior vena cava, returning to the heart in the foraminal valley here. This is now rendered using TrueView. So a little more resolution using TrueView. And one nice feature of TrueView, which you probably know if you use this technology, is that you can change your light source to highlight different structures in the heart. So for example, here, I'm illuminating the walls of the left ventricle to highlight the detail of the left ventricular chamber. In this image here, the light source has been moved to the right ventricle, outlining the characteristics of the right ventricular chamber. This can also be used to evaluate the mitral and tricuspid valves. So this is the tricuspid valve and this is the mitral valve, seen en face. And here is like an even more interesting example of a rendered view of the aortic valve, showing the valve opening and closing here. You notice the delicacy of the leaflets. You notice the commissures and leaflets when the valve here is closed and the valve opened. A few examples of imaging of the central nervous system. So this is an image of the posterior fossa using the C51 probe. And here an image of the posterior fossa using the EL184 probe. So higher resolution, same gestational age at 22 weeks. Zoomed up in the bipyramidal parietal diameter, notice here the caving of the septum pellucidum. Further zooming of the posterior fossa with more detail of the cerebellum. Here are the walls of the Blake's pouch and the Fox cerebelli seen very well in this example. More imaging of the posterior fossa showing the walls of the Blake's pouch, the cerebellum, a little bit of the hippocampus showing the temporal lobes here. And here you have the cavum septum pellucidum, the anterior horns of lateral ventricles, and the anterior portion of the corpus callosum, really well visualized in this image. A little more detail in that region, showing the corpus callosum again, the frontal portion of the corpus callosum, the frontal horns of the lateral ventricles, and the cavum of the septum pellucidum. Here in more detail, the transition between the cavum septum pellucidum, cavum septum virgae here, and here a little lower, the anterior walls of the fornix. Detail of the atrium of the lateral ventricle with choroid plexus filling the ventricle completely at this point. And here, using only to the imaging, exquisite imaging of the optic chiasm. So these are the optic nerves, the optic tracts, and the crossover in the suprasellar cistern. Here's an image of the midbrain. It's like in detail, showing here the cerebral aqueduct. And if you look carefully more anteriorly in the midbrain, you see these two hypoechoic round structures in the center that correspond to the red nuclei. Sagittal image of the head showing the corpus callosum in detail in this image. Here again, the posterior aspect of the corpus callosum with the splenium seen here. And here, you know, the visualization of the cerebellar vermis, the Pacman appearance of the cerebellar vermis with imaging obtained through the anterior fontanelle in the sagittal plane. Here's the same image now using microvascular flow imaging to delineate the cerebral circulation. So here you have the anterior cerebral artery and callosal branch of the anterior cerebral artery outlining the entirety of the corpus callosum. Here is like a perisagittal view showing the choroid plexus filling up the ventricle. You see here the hippocampus, and here's the column of the fornix going to the hippocampus. Another view with a better view of the fornix and hippocampus. Here's a comparison between MRI of the brain using T2-weighted images in the axial and sagittal planes in a patient with Dandy-Walker malformation. So here you have the splaying of the cerebellar hemispheres, you have the elevation of the vermis from the tentorium in the sagittal view, and here's the same cerebellum seen the same day at 31 weeks with ultrasound. Notice that once you overcome the difficulties in examining the posterior fossa due to poor windows, and you find a window to the cerebellum, you do see the details of the cerebellum better than on the MRI at this. Evaluation of the spine. So I showed you before a case of a tethered cord, right? This is the image of the spine, pretty similar to what we obtain in children that come for evaluation of tethered cord. So here you have the conus medullaris at 20 weeks and 2 days using the EL184 probe. So this is the conus medullaris, very well visualized here. This is the count from S5, S4, S3, S2, S1, L5, 4, 3, 2. So the conus is in normal position at L2, L3 for this gestational age. So no evidence of tethered cord. This is another example showing similar imaging with normal position of the conus medullaris. And I would say that we can image the conus medullaris with a lot of confidence at any gestational age using this probe, provided that the fetus presents with the spine up. Here's another image at 22 weeks of the conus medullaris. In this case, you will notice that the conus medullaris is lying lower in the spinal canal. So if we do the count, so this is the conus, and then 5, 4, 3, 2, 1, L5, L4. So this conus medullaris is low in position. So this is a diagnosis of tethered cord at 22 weeks of gestation. Another case of a tethered cord, now seen at 20 weeks and 1 day of gestation, in a thickened filum terminale, seen here. 3D imaging of the spine obviously is also possible using the V92 probe. And this is an example of imaging of the spine and outlining the spine to highlight the vertebral bodies as seen in this image here. Now with the line, the rendering line moved up a little bit to see the posterior elements all closed in the midline with no evidence of spinal dysraphism. Let's see how this technology plays in evaluation of a case of spina bifida. So this is a fetus with ventriculomegaly, posterior displacement of the lateral ventricles, very limited extra-axial fluid on the MRI. All of these imaging findings commonly seen in fetuses with spina bifida. Evaluation of the posterior fossa here shows a Chiari-2 malformation with herniation of the cerebellar tonsils through the foramen magnum into the cervical spine. And here at the bottom of the spine, we see a very large defect beginning in the upper lumbar spine or even thoracic spine and extending all the way to the sacral spine. So clearly seen on the MRI, both in the sagittal as well as the coronal planes. So what did ultrasound add to this case? With ultrasound, we were able to get high resolution images of the spinal defect. So this is the myelomeningocele, and we're able to count, with confidence from the fifth element of the sacral spine all the way to the thoracic spine. So this defect was seen between T11 and T12, counting from the bottom. Then we did three-dimensional imaging of the spine with the idea of looking at the count from above, so from the level of the thoracic spine. And here you see that the level of the defect here actually corresponds to T12. Here is another imaging, same case, going through the lower lumbar spine. Here seeing the placode and the nerve roots going to the placode. The placode is exposed to the amniotic fluid. Here's the cord being tethered to the defect and to the placode. Here you can follow the whole extent of the cord into the placode. Here's imaging of the posterior fossa by MRI. Notice here the cerebellar vermis and the herniation of the tonsils through the foramen magnum. And these are the images with ultrasound. So this is the banana sign that corresponds to the downward displacement of the cerebellum, seen very, very well with high resolution imaging. And here is the cerebellar vermis on sagittal imaging, clearly herniating below the foramen magnum into the cervical spine. So you see the fovea of the cerebellum coming, posterior and posterior inferiorly through the foramen magnum. A little bit of images of the placenta now. So these are images of the normal placenta at 26 weeks obtained with the EL-18-4 probe. You see the ecotexture of the placenta in high detail. You see the jets of the spiral artery that penetrate the placenta, seen here, and we're going to confirm this with Doppler in subsequent images here and there. Here you have the myometrium, you have the vessels of the myometrium outlined here and here. So very clear imaging of a normal placenta with normal interface between the placenta and myometrium. Now, if we superimpose on this placenta microvascular flow imaging, we can evaluate not only the maternal circulation, so these are arcuate arteries and then spiral artery jets. The spiral artery jets tend to go into these lakes in the placenta. But at the bottom here, we see also the fetal circulation branching off to reach the maternal surface of the placenta. So this is the fetal vessel, the branching into the villi, all going into that lake here in really normal anatomy and in exquisite detail. Microvascular flow imaging is also possible with the V92 probe. So this is one such example of the placental circulation, so showing a spiral jet towards the placental lake seen here. And this is the Doppler velocity waveform through that jet, showing that is an arterial high velocity, low resistance waveform from the maternal circulation. More images showing examples of normal placental vascular imaging using the EL-18-4 probe, looking at the detail. And now a little more with the video clips here. And other images showing now the fetal circulation. So in several images of the placenta, just highlighting in different cases that you can obtain really detailed imaging of the placental circulation, interplacental circulation using this type of technology. Now, this is for comparison, the same placenta using the same probe using color Doppler. So the sensitivity between one and the other method is significantly different. Now let's look at a case of a placental problem that was solved using this technology. So this patient was a 31-year-old in her 4th pregnancy, 2 prior cesarean sections for placenta previa, and she had suspected placenta accreta by ultrasound. She was referred to us for fetal MRI. On the image on your right, you see the normal myometrial interface here. You see that the placental tissue is bulging towards the maternal wall in this area. So these are 2 T2 weighted images that show the bulging of placental tissue. Here is the same placenta using high frequency ultrasound, the EL-18-4 probe. And you look at the placenta, you see the very heterogeneous nature of this placenta with multiple vascular lacunae that were not appreciated, as well in the MRI. Here is the area of placental bulging. And in the area of placental bulging, you see that there's a thin layer of myometrium that clearly separates the placenta from the adjacent maternal wall. So even though the placenta is invading the myometrium, it's not piercing through as it would see in a case of placenta percreta. So it was deep invasion, but not going beyond the serosa confidently seen with the high frequency ultrasound. In case we have questions of whether the placenta is invading the maternal wall, we ask the moms to breathe, and we see the movement of the placenta sliding away from the maternal wall, confirming that there's no adhesion between the placenta and the maternal wall in this case. This is another patient, a 26-year-old, second pregnancy. Prior placenta previa requires cesarean section. Also history of complex congenital heart disease. And the placenta previa had suspected morbidly adherent placentation. So these are the MRI images. This is a complete previa with predominance of the posterior component. Notice that on MRI, the placenta is highly heterogeneous. It has these dark hypointensity two bands. They are very characteristic of placenta accreta. Note also the bulging area of the placenta in this area and this area. What was interesting about this placenta is that the area that would have the most significant bulge was the posterior placenta. So you notice on the right lateral wall that the placenta is really bulging posteriorly here, and even more so here, where you actually lose the myometrium in this area. And you also lose the interface between the placenta and the psoas muscle. So at this point, the question was whether the placenta was invading the adjacent structures, in particularly the psoas muscle. We performed an ultrasound, and this is ultrasound with the V92 probe, showing that bulging area of placental tissue. Here with color Doppler showing the vascular lacunae, we know is a placenta accreta, but we wanted to look in detail of the interface between the placenta and psoas muscle. So we resorted to the EL184 probe, and you see that the resolution is much higher than in the previous exam. This is the psoas muscle here. This is the placenta, and it seems that the placenta is really piercing through the myometrium and touching the psoas muscle. Now, to determine whether there was invasion or not, we ask the mother to flex her legs and contract the psoas muscle. And here you see the psoas muscle sliding away from the placenta, showing that there was no adhesion of the placental tissue to the psoas muscle. At the time of hysterectomy, the placenta was going through the myometrium, so was a placenta percreta, but there was no invasion of the psoas muscle as we noted on the prior ultrasound. So this concludes our presentation. I thank you very much for participating in this virtual meeting, and really wish that we can have a chance to meet personally in person at a future time. Thank you very much.